Initially, we had discussed about the aseptic viral meningitis. Now, let us move the topic towards enteroviral infections. Entero, that the viruses where they reside are GI tract as well as nasopharynx. So that is why they are called as entero plus rhinoviruses. They are host specific. They usually infect only one species. Let us see the classification of enteroviruses. Poliovirus, Coxsackie A, Coxsackie virus B, ecovirus. Ecovirus stands for it stands for enteric cryptopathic human orphan virus. And new enteroviruses. Now let us see the disease and its causative organisms, the causative viruses. Poliovirus causes paralysis, it causes polio. Aseptic meningitis is caused by all these, PCCEE. Encephalitis, hand, foot, mouth disease, acute hemorrhagic conjunctivitis caused by enterovirus 70. Now the book gives us a case, 10-year-old boy with fever, headache, sore throat, vomiting, weakness in his right leg, no vaccination history, throat swab and rectal swab show virus growth, PCR is positive for poliovirus type 1 and diagnosis is poliomyelitis. Now let us get into the picture of poliomyelitis. So let's take an overview before and then get on to what the book says. It will make the concept more clear. Now talking about poliomyelitis caused by a virus, poliovirus of the family Picornaviridae. Picornaviridae, Pico means 10 to the power minus 12 meter. That means that's a very small virus. From the genus enterovirus, it's non-enveloped, single-stranded RNA positive, positive sense single-stranded RNA virus, and icosahedral is its shape. That is 12 vertices and 20 facets. So it's a small, naked, tough virus. It survives in gut and the environment. So let us see the entry from the mouth to gut. From contaminated water and contaminated food, virus enters via fecal-oral route. In throat, what happens? Virus and in intestine, what happens? Let us see. Virus, it attaches to the CD155 receptor and it multiplies in the oropharynx and the intestinal mucosa, the Peyer's patches. Okay, so that is why it is causing sore throat. It is multiplying in the oropharynx. Next thing that happens is the primary viremia. The virus is in the blood. It spreads to liver, spleen, lymph nodes. In most of the people, the infection stops here, and that is called as abortive poliomyelitis. It causes fever, sore throat, and malaise. And this is in 90 to 95% of cases. But the other thing that happens in the rest cases is the secondary viremia, where the danger actually begins. In some patients, virus multiplies more. It re-enters the blood in high amount, and now it can cross into CNS. So now let us see the CNS invasion, where the real disease starts, where the anterior horn cells of the spinal cord are the target of the virus, and the motor neurons in the anterior horn cells, they are affected, and there is no sensory loss, we have to remember. And the reason why poliovirus significantly affect motor neurons but not sensory is because of the receptor and the tropism. The poliovirus, it binds to the CD155 poliovirus receptor, and this receptor is highly expressed on the anterior horn motor neurons. Okay, and inside the spinal cord, what is there? Virus enters the motor neuron, it replicates in the motor neuron, and it lyses the motor neuron cell. So, and inside the sensory neurons, what happens? It either there is lack of the sufficient CD155 receptor, or they are less permissive for replication. So motor pathway is destroyed by the virus, but sensory pathway is kept intact. Okay, now let us see next thing, that is what happens when the neuron is destroyed. Its muscle, the muscle, it loses its innervation, and the muscle becomes flaccid, hypotonic, and areflexic. As a result, there is acute flaccid paralysis. Now let us see the types of polio. Abortive polio, which is most common, mild fever, no CNS involvement. Non-paralytic polio is there. Aseptic meningitis, like symptoms are there. Then neck stiffness. Paralytic polio, asymmetric paralysis is there. Legs affect more than arms. The subtypes of paralytic polio are spinal, bulbar, bulbospinal. In spinal polio, there is limb paralysis. In bulbar polio, it affects respiration. The cranial nerve nuclei that are originating from the brainstem, that is from the medulla oblongata of the brainstem, and medulla oblongata is nothing but bulb, it is called, and hence there are various cranial nerves taking origin, and if they are affected, then they will cause the respiratory muscle innervation will be affected, and hence it will be very dangerous. And bulbospinal polio means both. There is limb paralysis as well as respiratory muscle diaphragm paralysis will be there. Now the diaphragm is innervated by vagus nerve, the 10th vagus nerve. Okay, now let us see. Lab diagnosis. Stool is most important. Throat swab, CSF, which is less useful for virus isolation. Tests are done in cell culture. Virus is isolated. RT-PCR, it's a gold standard. Serology is less used. CSF findings are just like that of the aseptic viral meningitis. Since virus is invading the CSF, it will cause cell-mediated immunity response, and there is mild lymphocytic pinocytosis and slight increase in the protein. Same pattern as this. And the treatment is no specific antiviral treatment, but management is done by supportive care, ventilation, and physiotherapy. Key is to prevent complications and not to kill the virus. It is to prevent the complication. Prevention is done by oral polio vaccine. Now let us see about oral polio vaccine. It's live attenuated sabine. It's given orally. It reduces IgA in the gut and blocks the viral transmission in blood. The risk is of VAPP, that is vaccine-associated paralytic polio, and there is also something VDPV, vaccine-derived polio virus. Okay. Then talking about IPV, that's inactivated polio vaccine. It's killed Salk KK, and it's injectable. It is safe. There is no reversion, but less gut immunity, provides less gut immunity as compared to the oral one. Now the question about OPV, why OPV is better for community protection than IPV? Because OPV produces immunoglobulin A in the gut mucosa, which prevents the viral transmission. It stops the entry of the virus, and the transmission chain, it is broken. So for that reason, it is better for community protection. Whereas the IPV, it produces IgG in the blood, and that prevents the disease, but the viral entry can still occur. The virus can still multiply in the gut, and people, they can still spread the infection by fecal oral route. Now OPV, it provides intestinal immunity by producing IgA, it blocks transmission, and IPV, it gives systemic immunity by producing IgG, and it prevents disease only. Now talking about the risk factors that are associated with OPV, oral polio vaccine, are VAPP, that is vaccine-associated paralytic polio, and vaccine-derived polio virus. These are rare risk factors. They are rare risks that are associated with live OPV, but they differ in their scope. As in VAPV, it is sporadic individual case of paralysis, while VDPV, that is virus, the vaccine-derived poliovirus, it occurs when virus mutates and spreads in the community. So VDPV, so it's like spreading everywhere in the community. VAP cannot spread to others, but VDPV it causes outbreak. Now next thing is that why is flaccid paralysis? Because if in the anterior horn cells these are damaged, anterior horn cells neurons are damaged, then the LMN, that is the lower motor neurons, that is also destroyed. So muscle stimulation will not be there and muscle becomes floppy. And so yeah, element lesion is there, flaccid paralysis will be there. Now talking about the in mouth, the virus has entered, it has went to gut, entered blood, entered CNS, it has targeted anterior horn cells, it has caused the flaccid paralysis asymmetric, and the diagnosis is by stool and PCR. And prevention is by OPV, IPV, and these questions can easily be done by me. First two questions I have discussed. The third question is why is paralysis asymmetric? Asymmetric because there are the anterior horn cells, this destruction will occur, and there will be patchy destruction. All of the anterior horn cells of the right and the left side won't be together, there won't be together destruction altogetherly. Rather patchy destruction somewhat here and there. So not all segments of or both the sides equally are affected. That is the result. One limb is more affected than other, and there is irregular destruction. Now, the next thing to be considered is why is stool the best specimen for diagnosis. Now the virus had entered gut, it was multiplying in the gut and in the intestinal mucosa and Peyer's patch. As a result, large amount of virus is shed in stool compared to blood, where transient viremia for short period of time viremia is there, and in the CSF where low viral growth, low risk. How do you differentiate polio paralysis from Guillain-Barre clinically? Okay, Guillain-Barre syndrome. Polio patient will present with asymmetric paralysis, fever at the onset, because virus has entered, immune reaction will take place in body, fever will be there. No sensory loss. Okay, this is important to note that there is only asymmetric paralysis, motor paralysis, but no sensory loss, element signs, hypotonia and areflexia. But a Guillain-Barre syndrome patient will present with symmetric and ascending numbness. Numbness, that means that is something related with sensory neurons, followed by severe weakness and diminished or absent reflexes over 2 to 3 weeks. Then what will happen? Autonomic dysfunction will be there. Oculobulbar palsies will be there. Ocular, that means related to the eye movement, and bulbar, that is related to the medulla oblongata palsies will be there. So it's ascending numbness and weakness with low element findings with respiratory or GI prodrome. It is due to Campylobacter jejuni. It is most common infectious agent, and as a treatment, that's not very necessary thing. So symmetric acidic paralysis starting in legs moving upward, and sensory symptoms present like tingling. No fever at onset, and usually it's post-infectious fever will be there. Okay, no fever, but in polio patient there was fever, okay, fever at onset. Key differences about polio and GBS, read all these, okay? The cause, the pattern, the direction, sensory effect, and fever. Okay. Now talking about let's ask the question that why do certain conditions push the virus into spinal cord, hence causing paralysis? And the conditions that we are talking about is first of all IM injection during fever. Okay, what IM injection does is needle will cause muscle injury and inflammation, and local motor nerve endings will get irritated. Now, virus is already circulating in blood. Now, it gets attracted to the injured muscle and the motor neuron, and there will be retrograde axonal transport from the muscle to the motor neuron and the spinal cord, and hence it will affect the anterior horn cells and cause paralysis in that injected limb first. Okay. Now, the next thing is about strenuous exercise. It will cause microtrauma to muscle fiber. There will be increased blood flow, increased metabolic activity there. So, inflammation, active muscle that will attract virus, and hence it will use the motor nerve pathway to the spinal cord, and hence the same retrograde movement, axonal transport. Then, in pregnancy, what will happen is there is relative immunocompression, hormonal changes are there, increased blood volume is there. Virus will replicate there more. Viremia, it becomes strong and prolonged. Now, virus is in blood. There are higher chances of CNS invasion. Yes. In tonsillectomy, let's go to throat. It's an initial replication site, we know, of the virus, which causes sore throat. Poliovirus, it multiplies in oropharynx tonsil, but after tonsil removal, the local barrier is removed, and there is raw surface for the virus to enter the blood, and which leads to increased viremia and higher CNS invasion risk. Okay, so putting it all together, all these causes, the IM injection, strenuous exercise, pregnancy, tonsillectomy, they are the risk. There are special conditions in which there will be chances of poliomyelitis. Okay, how does polio patient recover? Now we have to understand how does a polio patient recover. The damage phase is when the anterior horn cells are destroyed. Then what happens is muscle flaccidity occurs, and there is paralysis. Okay, next thing is the body tries to compensate for the flaccid muscles. The body goes into surviving motor neurons, and they say that some of us are gone, but we will take over their work. And the mechanism they do is collateral sprouting. Surviving motor neuron, they send new branches, they sprout out, and they connect to the denervated muscle fibers. And one neuron now controls many fibers, and that forms a giant motor unit. As a result, muscle, it regains the strength partially. Now the mechanism 2 is that of reversible neuronal dysfunction. Not all neurons are dead initially. Some are inflamed and some are temporarily dysfunctional. As inflammation settles, these neurons start working again. As inflammation is fading, these neurons will start working again, then there will be improvement in strength. Now think as the stunned but not dead neurons. Third mechanism is that of muscle adaptation. The remaining muscle fibers, they will do hypertrophy, and physiotherapy will improve the efficiency of contraction. So function improves even without full neuron recovery. But important limitation, we have to understand that the dead neurons, they're gone forever. No regeneration of CNS neurons is occurring. So recovery is partial and it is not complete. Now, let's see a case where a child is initially unable to move his leg, but after a few weeks and months he starts walking again. It's not because the virus has reversed, it is because the remaining neurons, they have took over the job. And their mechanism could be collateral sprouting, reversible neuronal dysfunction, their inflammation has settled and they have started working again. Or it can be that the muscles have hypertrophied and they have gained their contraction efficiency through physiotherapy. Okay, so the boy is able to walk again. Answer this. Now let us see what is a post-polio syndrome. Let us see a case where there is a patient who has recovered polio, and years later, he, after 30, 40s, wait, I'll read it again. Into life, let's enter into the life of a recovered polio patient years later. That patient has survived childhood polio, adapted, and lived normally. And now in his 30s and 40s, something strange begins again. That is called as post-polio syndrome. What you see clinically here, the new muscle weakness is there, severe fatigue, muscle pain, difficulty walking again. But important to note that this happens after 10 to 40 years after recovery. Now we had seen the mechanisms of recovery of the neurons and the muscles. After 10, 40 years, PPS will occur. What actually is happening there is the many anterior horn cells have died during original polio, and some survived, tried to compensate. But how did they compensate? We have seen collateral sprouting, one neuron innervate, many muscle fiber form, giant motor units. Now patient comes and PPS has happened. Let us ask why has happened. Overworked neurons, they start failing. After years, the enlarged motor units, they have overburdened. Constant stress and metabolic exhaustion has occurred. Now slowly the axonal sprouts, they have degenerated. Neuron cannot maintain all the connection. As a result, muscle fiber, they will lose their innervation again, and weakness will return. Now, is this reinfection? No. Virus has not come back again. It is not an active infection. It is just a neurodegenerative process. Now, let us see the clinical features of PPS. New onset weaknesses, it is progressive. Disproportionate fatigue is there. Muscle pain, atrophy is there. Cold intolerance sometimes. Reflexes have decreased. Element pattern, again, flaccid paralysis. Diagnosis is by, it is clinical diagnosis mainly, but its criteria is see the history of previous paralytic polio, long stable period, new weakness or fatigue. EMG, it shows chronic denervation and renervation. Treatment, there is no cure, but management could be done. Important to notice, avoid overexercising. Now, to differentiate PPS from new polio infection, virus is not there, here is there. Fever, no, yes. Onset, it's gradual and it's acute. Causes neuronal exhaustion, and here causes viral damage. Now, why PPS is more common in women? Let us see. After polio, the surviving neurons are already overworked. So, in women, there is less muscle mass. There is more relative load per neuron. So, as a result of aging and hormonal effects, there will be earlier and more frequent failure of the motor units. And hence, it will cause PPS. Now let us, another thing we have to see is that virus, it will mainly be inside the anterior horn cells, intracellular. So CSF viral load is low. But low viral load does not mean there is zero viral load. What actually leaks into CSF is when neurons get infected, the anterior horn cell neurons get infected, neuronal injury will be there. Cell lysis and damage, viral particles and RNA fragments will leak out. And local inflammation will be there. Blood-brain barrier, the blood vessels which are lined by very tight epithelium, very tight endothelium. Blood-brain barrier will slightly become permeable. Small amount of virus RNA fragment may enter the CSF. So CSF contains tiny amounts of viral RNA, not abundant. And this tiny amount of RNA, it will be useful in RT-PCR or PCR. And hence by CSF investigation, we can find out the virus presence. Now all these things, they are, okay, I'll read them fast now. So agent poliovirus, its nature we have seen what it is. Then its morphology, let us see structure of poliovirus, RNA, viral capsid, shell, membrane, and this is glycoprotein. Now these are the viral protein 1, 2, 3, 4. Okay, and poliovirus is made of these proteins. This is a single-stranded RNA, positive sense. VP1, it faces outward, contains antigenic site. And there are neutralizing antibodies that act against the VP1. Okay, next thing to be seen is the antigenic types. Type 1, type 2, type 3. Two antigens are there, C and D. C is empty, non-infectious, non-protective. D antigen is a whole virus. It is protective and used in vaccine. And heat converts D antigen into C antigen. And only D antigens, the whole virus, the protective ones, they give immunity and they are used in vaccines. Resistance, polio is resistant to ether, from bile and digestive enzymes. So it survives in intestine easily. It survives feces, cold, killed by heat at 55 degrees Celsius, formaldehyde and chlorine. Most important is the pathogenesis, entry via contaminated food water. First landing, it reaches in oropharynx, then intestine pair patches. When it reaches oropharynx, it causes sore throat. It starts multiplying in the gut and the oropharynx. Then it does the lymphatic spread. It goes to regional lymph nodes. Here we can see all the lymph nodes. It has gone from here. Then it will, the regional lymph nodes like tonsils, it will go to, okay, virus will go to regional lymph node and reticuloendothelial system. It's a reticular network of macrophage system, phagocytic cells, tissue macrophage monocyte derived from bone marrow. And these are primarily found in liver, Kupffer cells, spleen and lymph nodes. RES, it clears the blood of foreign debris. Aged RBC antigens acting as a crucial defense system. So this is a liver, spleen, base patch. Here what is present? Reticuloendothelial system is present. It's a crucial defense system. All the antigen, foreign debris is cleared out. And there is a primary viremia, that is, now the virus had gone to the lymph nodes. From the lymph nodes, the virus will enter the blood. At this stage, mild symptoms like fever and malaise will be there. Lymph node anatomy, let us see. There, first of all, there is a capsule. Then there is a sinus. Sinuses are there. This is a lymphatic nodule. And then there is germinal center. These are the afferent lymphatic vessels, and this is an efferent exiting lymphatic vessel. Okay. Secondary viremia is about virus multiplies more and re-enters the blood. Now viral load is high in blood. There is CNS invasion. Virus, it reaches spinal cord, brain, through bloodstream, through peripheral nerves, axonal transport. Target destruction, virus attacks anterior horn cells. Why? Because these are the motor neurons. They have receptor for the poliovirus, that is CD155. What happens inside the neuron? Virus multiplies, nasal bodies are degenerated. Chromatolysis will occur and the cell will die. As a result, motor neuron is destroyed, element destroyed, no signal to muscle and flaccid paralysis. Only motor neurons are affected, so sensation is normal. Reflexes are lost and muscle tone is decreased. Now let us see about the spinal cord cross section. The red thing that we see is the motor pathways, motor and descending pathways from the thalamus, from the all the extrapyramidal and the pyramidal tracts that we will see first of all. Pyramid means brainstem, that are coming from the midbrain, pons and medulla. Okay, as well as from the thalamus structure. So first of all, here is pyramidal structure. Let us see first from cortex, that is coming is anterior corticospinal tract. Extrapyramidal are vestibulospinal, olivospinal, reticulospinal, and these is rubrospinal tracts. So all these anterior horn cells के जो motor वाले जो tracts हैं, they will be destroyed. Now let us see the types of polio. Most of the infections of polio, they are asymptomatic. 90 to 95% of these are asymptomatic. And inapparent infection is there. Abortive polio is there. Paralytic polio is a major illness. Fever returns. Biphasic fever is there. Neck stiffness, meningitis signs are there. Then suddenly weakness will shift to paralysis. Paralysis includes placid, asymmetrical. It starts focal and it spreads in 3 to 4 days. Types of paralysis are spinal, bulbar, pulvospinal. We have seen. Bulbar means nothing but bulbar refers to medulla oblongata, and the muscles that are affected in the bulbar paralysis are the muscles that control that are used for swallowing, speaking, chewing, and breathing. And if breathing muscle is destroyed, then it's very dangerous. Okay. Now the special risk factors for polio are pregnancy, strenuous exercise, tonsillectomy, IM injection during fever phase, and these all increase the risk of paralysis. Now outcome of the paralytic polio, let us see. Mortality around 5 to 10%. Respiratory failure is the cause of death, diaphragm paralysis. Recovery by some neuron destroyed permanently, some are partially damaged. Nearby neuron try to compensate by regeneration, by sprout formation. And recovery starts in a month or 2 months. Max recovery by 6 months. But not all neurons recover. Residual paralysis remains. Rare complication, myocarditis and lymphatic hyperplasia. Non-paralytic polio. Sometimes infection stops at meningitis stage only. So no paralysis, only fever and neck stiffness is there. And this is aseptic meningitis form of polio. Post-polio syndrome we have seen there is a patient 20-40 years later comes, and earlier some neurons had died, remaining neurons had compensated. But after years, compensated neurons also start failing, and there are symptoms like new weakness, new muscle atrophy, fasciculations, fatigue, pain, and seen more in women due to the factors like low muscle mass and hormones and more workload on the less muscle mass. Okay, so delayed degeneration of previously compensated motor neurons. Okay, that is the reason why post-polio syndrome occurs. Lab diagnosis, let us see. The goal is to detect virus or its RNA, and we see the specimen that we take are throat swab, feces, it's most common, blood, and CSF. CSF finding are viral. We know very well that is lymphocytic pleocytosis, normal glucose, slight increase in protein. Virus isolation from feces, it is most useful. Virus present in 80% in the first week, in third week 50%, and sixth week it is 25%. So 80, 50, and 25. Always take 2 samples on different days of feces. From throat within 14 days, from blood only during early viremia, not very useful. And from CSF, we do not isolate. We rarely isolate virus. We grow virus in monkey kidney cell culture. Molecular diagnosis, let us see. Using RT-PCR, it is a gold standard. It detects viral RNA in CSF. RT-PCR, it needs only genetic fragments, but culture, it needs lots of live virus. So for CSF culture, for viral isolation from CSF, virus are not that much in amount, but RT-PCR can be done. Then let us see sequencing. Why do we sequence virus? Because 3 types exist in population: wild virus, vaccine strain, and vaccine-derived poliovirus. Okay. Uses of sequencing: identify the genotype, trace the geographic origin, differentiate wild versus vaccine strain, and so infection has occurred in the gut, in the oropharynx, spread has occurred, it has gone to spinal cord, damage has occurred in the anterior tonsil, outcome is paralysis, asymmetrical paralysis, recovery is incomplete, and diagnosis is by stool and RT-PCR. Most important point, death is due to respiratory failure, stool sample is best sample, CSF lymphocytes are there, normal glucose, increased protein, virus not isolated from CSF because of its lesser amount. RT-PCR is confirmatory post-polio late neuron degeneration. Why? Because of the load. It has failed to work for a long time. Now there is a thing of CF test, that is C antigen early disappears and D antigen late, it lasts for years. Now the vaccines are OPV and IPV, Sabin and Salk. Sabin is light injected, Salk is killed. Oral injectable immunities gives mucosal, systemic, only systemic, IgA and IgG. Herd immunity. It prevents the entry of organism in the blood, and this does not prevent entry of organism, but it allows the viral entry but kills the virus. Now we know why lymphocytes are in the CSF, why there is normal glucose, why stool is the best sample. Immunoprophylaxis, passive immunity we don't give, gamma globulin देने का कोई मतलब नहीं होता. Virus is already inside the neurons. Active immunity देते हैं, vaccine देते हैं, IPV Salk and OPV Sapin. It is a formalin killed virus type 1 to 3. Dead virus injected, safe but limited, given IM subcutaneous. Schedule at 3 doses, 4 to 6 weeks apart. Booster after 6 months. And what it does, it produces IgG in the blood, protects you from paralysis, but virus can still grow in the gut and spread continues. OPV Sabin is live virus, oral, spreads like a training army, live attenuated virus. It multiplies in the gut and it produces IgG in the blood and IgA in the gut mucosa. Why this is powerful? Because virus replicates. It stimulates strong immunity by producing IgG and IgA, that is IgA is antiseptic paint of mucosa, and the virus gets excreted. It spreads to others and it provides herd immunity. Prevents viral entry into the blood, but the virus is replicating in the mucosa and producing IgA and IgG. And in here, viral entry is there. Virus is able, in Salk IPV, virus is able to get into the blood, but it will be killed. It's a dead, killed type of virus. And it will only produce IgG. But virus can still grow in gut and spread continuous. Now VDPV and VAPP we have seen. Why OPV it fails in tropics? Other enteroviruses provide competition, diarrhea, virus is flushed out. Breast milk, there are antibodies that kill the vaccine virus. So vaccine doesn't get time to replicate in the tropics, but the booster doses and the next doses they can compensate for it. Why to combine IPV OPV? OPV is what? It protects the community and IPV protects the individual. Eradication कैसे हुआ? Pulse polio day and all it is given. Okay, now I'm done with poliomyelitis.